for MRC volunteers, and our presenter is Dr. Rebecca Vargas-Jackson. She's a surgeon and infectious disease specialist. She's also bilingual English and Spanish. Dr. Vargas-Jackson has been working for over 25 years as a subject matter expert for a variety of agencies and organizations, developing assessments and providing training, technical assistance, capacity building, and M&E. She's been affiliated with George Mason University as research faculty in the College of Health and Human Services. And from 2020 to 2022, during the COVID-19 pandemic, Dr. Vargas-Jackson served in the capacity of public health physician at the Virginia Department of Health as a key member of the Cultural and Equitable Communications team. And that's about a skosh of her actual biography. She's done a lot of amazing things in her career. So I'm going to go ahead and turn that over to you, Dr. Vargas-Jackson. Thank you so much for being here.
Thank you, Kate. Let me see if I can share my screen. Here we go. Okay.
Perfect.
Hello, everybody. And today we're going to be talking about diversity, the key for good communication. So we know that communication is a basic tool that we need in life. There's no other way to highlight that importance. And without communication, we really cannot understand, we cannot assess, we cannot inform, we cannot warn, mitigate, or take actionable approaches to interventions. So when we have effective communication, it leaves all the parties very satisfied and feeling that they accomplished something. So by delivering this clear message, there is no room for misunderstandings or alterations of the message, which decrease the potential for doubts, misleading advice, or conflict. But to produce this clear message, we need to understand the culture of our target population. So the culture of health is built on the fact that each person needs access to information and care based on a variety of factors, like literacy, health literacy, culture, language, generation, age, belief, disabilities, etc. So the way we communicate with each person, it's one of the most important roles in life. Communication and access to information, as I mentioned, varies depending upon the diversity of our populations. And as MRC volunteers, we constantly interact with diverse population groups. So, as I mentioned, the age, generation, sex, sexual orientation, faith, beliefs, religion, language, disabilities, education, literacy, health literacy are some of the factors that influence the access to information and care. But all of these topics that I have mentioned are taught in a 1 or 2 semesters at the university or higher education institutions. So during this presentation, I'm going to mention just some of the most important areas of diversity that can help us to improve communication skills and facilitate very clear understanding and actionable messages and warnings. The emphasis on actionable, because sometimes the message can be clear, but if we don't know the culture of particular groups, they may not be actionable. So let me see if I can move to the next slide. That will be interesting. Okay, there we go. We're going to have just kind of 4 learning objectives for this presentation. The first one is going to be increase the awareness of the importance of diversity, culture, and language in the role they play in health. The second is going to be increase the knowledge and understanding about the many elements that play a role in a culturally tailored communication. The third, understand why health literacy is a key element for health communications and maintenance of good health. And the last one is going to increase the knowledge and the importance of messaging transcreation for effective communication with diverse populations. And remember, always one size does not fit all. The question is, what can we do without communication? And probably you know almost nothing. So culturally tailored communication is key for public health preparedness. For everything we do as volunteers, communication is everywhere there. But let's remember, we are not rational creatures who feel. We are pretty much emotional creatures who rationalize. So emotions are cultural data that requires training to be able to interpret it. And culture leads individuals to regulate their emotions. And we know how emotions play a role everywhere. And the culture modulates the link in between the emotions and well-being. So that was the first objective that we have, which is increase the awareness of the important role that diversity, culture, and language play in health. And we are volunteering in different areas that pretty much are related to health issues. But before I start, I'm going to ask everybody if you can leave your cell phones in one little corner, and let's try to see a little bit about yourselves. So in the chat room, and Kate is going to help us with that, I'm going to read one question, and I want to see with a simple yes, no, or not sure, what is your answer. The first question is, do you have any ancestors, I'm talking about 10, 20 generations ago, that they were born outside of the United States? And let's see what we have, Kate.
Yes, all yeses so far. Yes, myself included. Yes, yes. One no. Yes. Yep. Mother born in the Ukraine. Mostly yeses, a couple no here and there.
Okay, so the no's, I believe that they are people who are part of some tribes, indigenous tribes, because yes, they were originally from the United States. So the second question is, do you speak another or several languages? Let's see, what do we have?
This looks like maybe 50-50-ish.
Okay, good.
Some not fluent, yes, just a little.
Okay, okay. The third one is, have you traveled outside of the US because you went to college or university, because you went on vacation, or maybe it was spring break?
Yes, this is mostly yes. The majority, yes.
Perfect, perfect. So the fourth one is, do you like Chinese music? Yes, no, or not sure?
Not sure, don't know it. Some no's, some yeses, a very much yes. This is probably like 33% of each, you right? Like a third of each.
Okay. And do you like Peruvian food?
Yes, I love Peruvian food. Lots of yeses. Never had it. A couple not sures, don't know. Had it once and it's nice.
So you can see in the question 4, my message was not clear because I didn't tell you modern Chinese music, the Chinese music that they play in China, 14th century Chinese music. So if I don't give you the proper information, there are going to be a lot of not sure. So that is the power of communication. If I don't ask the right question, you are not sure of what is your correct answer. So let's keep working on that. And as I mentioned here, we're going to talk about the diversity, and pretty much culture and language play a very important role every time we talk about that. And as you can see in our group, that is not such a large group, we have so many people with different answers to very basic questions. That is diversity. So if we want to talk about diversity, I'm going to let you read the definition because I'm not a person of definition, but just put it over there because I want everybody to be on the same page. But I want to remind you that diversity means really understanding that each individual is unique and recognizing our individual differences. So we are probably different age and races and ethnicities and sex and heritage, and we have equity issues, and we have family differences, many of them that play a role when we try to communicate among ourselves. So there are some diversity topics that we need to take into consideration. Again, this is a one semester class, at least at Mason, but I'm going to mention some of them. Culture and cultural competence and cultural awareness and humility. Pretty much there are several hours of classes on that. Age and generation issues is very important. If you see down there, in our census, we could see that in just a century, we have gone from a pyramid to a pillar. That means that the population we thought we knew is not anymore. There are more aging populations here that we are not thinking about when we communicate with people. Same thing is if we're looking about sexual orientation or gender identity, racial and ethnic diversity, people with disabilities. Many times we don't remember first time that there are people with disabilities that require different communication schemes. So rural and urban, bias, stigma, literacy, language diversity, and there are many more that we don't have really the time to mention. So let's start with culture. And culture is pretty much what we are. It's not other way of presenting it. It defines what ourselves feel, what are we informed about, how we acquire information. As you can see, are the attitudes and the beliefs, the language, the food that we like or dislike, the behaviors, the rituals, and everything that make us what we are. In life or health is pretty much a cultural construct. So culture will define how life and health are perceived. And I promise you that the way you perceive life and health is not exactly the way that other people in different regions or countries, even in Virginia, rural and urban, are perceiving. And so how healthcare information is received. Not everybody has the same way to get healthcare information, meaning I bet that not all of you wake up every morning and go to log into the CDC to see what is new in health. So everybody has a different way, and that is cultural, speaking that everybody has the different way of doing things. And talking about rights and protections, wherever I feel is a right, some other people may not feel is a right, and it's culturally defined. And same goes for everything. Who should provide advice for the problem and the paths that we need to follow, our politics, our beliefs, etc. We have different ways of analyzing and following paths. I brought this issue of the continuum of cultural competency. This is a total different training session. I just brought it because sometimes when I'm talking to people, they say, oh, I took a 45 minutes training, so I'm culturally competent. Sorry, but I have to tell you, you're not. Because cultural competence is pretty much a journey. It's not a destination. Every day we learn something about culture and we teach something about culture. And let's go about the diversity that we have in communication, because cultural communication is what we call intercultural communication or cross-cultural communication. And that means that we need to understand that there are differences in how we communicate with different groups. When we're talking with older adults in writing, we cannot use font 8, and we cannot use 20 pieces of information in one pamphlet or so. Perhaps we are not going to use social media that much. So we need to start looking into the different groups and how we are going to communicate with them. Same thing if somebody speaks another language, we're going to need an interpreter. But don't forget about people who may need sign language as well, and take that into consideration every time we communicate with somebody. What am I talking about languages? Well, I'm talking about languages because I don't want to tell you what the language is, but what I can tell you is like we have approximately 7,000 languages currently spoken in the world. And sometimes we are losing languages because people is dying and the communities are disappearing. But if you see that, and one example that I got from here, from the US, is that in the 5 boroughs of New York City, we have 500 different languages. So if we would like to communicate with everybody in New York City, we need to learn the 500 different languages? I don't think so. But there are so many ways of communicating if we understand that they are of these language differences. In Northern Virginia, I think we have about 250 to 300 languages spoken. And that is what we need to think about every time we are trying to communicate with people. And yes, the interpreter, and there are some other ways of improving communication with people who's not speaking the same language we are. And then let's go for culture of health, because I was talking about culture of health, and what is that? In culture of health, as is defined there, is in the one in which we have this well-being, but that can flourish regardless of the geographic, demographic, or social sectors. And it's not happening. Well, it's not happening here. It's not happening in many places, but we are trying to get to that particular goal. And that particular goal will take us to a place in which we foster healthy, equitable communities. That is what we would like to do. And it guides public and private decision making. So every time it's a new policy, it should be with the goal that everybody can benefit of this well-being. But more important than that is that we can make educated choices and lead to healthy lifestyles. And believe me, people doesn't make educated choices. When they tell you that you have this test, this procedure, or this surgery, they give you a ton of papers, and at the end, one nurse or so is going to, in summary, this is what you need to do, and you sign. That is not an educated choice. Pretty much we're signing because we want the test or we believe we need the test. So to have these educated choices, it's really the culture of health that we are looking for, and health literacy, one of the most important things. Again, let's leave our cell phones, go to the chat room, and in a few words, let me know something about your culture and the culture of your ancestors. So I can tell you, in my culture, I am from Peru. We speak Spanish. So what about in your cultural group? And Kate, what do we have?
We have Greek, English, German, Polish, German and French, German, lots of English, Arabic from Egypt, Gaelic, French, lots of different things.
Yeah.
Lots of English, Afrikaans, French, German,
Okay.
English, Italian, Croatian, and Swedish, all from one person.
So we see how diverse we are. And that is very good. My
The
second
language for
question
the
would,
Black, that's right.
good. My second question is my preferred food. And in my case, my preferred food is ceviche. So I want to hear about what is your preferred food? What do you like the most?
Mediterranean fruit.
Wow.
Spaghetti, Italian, mac and cheese. West African, stuffed cabbage, all different kinds, Chinese, pasta, Italian, Nana's lasagna.
Thank you. I'm hungry already.
I know, I'm starving. Indian food.
Okay. And the third one is going to be in the most common religious or belief that we have with our ancestors or families. In my case, I'm from Peru, so I'm Catholic, and so many members of my family. What about you?
Catholic, Episcopal, Christian, Baptist, Jewish, Methodist. Ooh, they're going so fast. Islam and Christianity, Lutheran, Catholic, Indigenous beliefs, Catholic and Jewish, Pentecostal. We believe in the one God, Christian, Presbyterian, Catholic.
Okay, fantastic. Thank you for your answers. And the last one is, tell me something about your cultural background. And for me, let me share that my family comes from the south of Peru, a town or city called Arequipa. What about you?
Farming, farmers. Let's see. Farmers, trades, timbermen, farmers. My family is from County Cork, Ireland. First in family to be born in Virginia. And my ancestors came on the Mayflower. Educators and laborers. You guys are going so fast, I can't catch them all. I'm sorry. Service-oriented Italian peasants. Educators, lawyers, doctors. Grew up in the deaf community in Chicago. Came through Ellis Island. Scientists and teachers.
Okay, thank you so much, Kate, and thank you all of you for letting us know a little bit about the cultural background that you have. And you can keep writing because we can read it at the end of everything in the presentation. Let's go for the second learning objective, and that was increase the knowledge and understanding about the many elements that play a role in culturally tailored communication. So let's keep moving on to that. And then what is culturally tailored communication? So a culturally tailored communication is just an ability that we have to take a basic communication model and make him fit, making appropriate to the cultural group that we are trying to convey information to. But figure it out, 500 language. I figured that there are 500 cultural approaches to life. So we couldn't do it. We couldn't do it if we don't involve the stakeholders. So it's very important to involve the stakeholders in the development of the communication and the monitoring and evaluation process, because in that way we are completely sure that whatever we are trying to convey as information, it's really a culturally tailored communication. And then when we're talking about this issue of culturally tailored communication, is because the cultural diversity, you can see how many of you have so many diverse issues in your life. And we are from Virginia. We're from the same state. But cultures are like that. And understanding cultural diversity really is that we are respecting the differences of other cultures. And we need to understand the other culture to be able to communicate. And that is not kind of a personal thing or Virginia thing or US thing. As you can see there is a World Day for Cultural Diversity, which is May 21st. So that is very important because that improves our communication. And as volunteers, that is what we like to accomplish, to get there. And so the message is very clear for the people we are talking to. When we talk about cultural diversity, basically people is thinking about language and race and ethnicity and religious issues and political views. We're going to talk a little bit more about other issues, but I'm not going to get to the in-depth information of each of them because of time constraints. One thing that is always interesting when we communicate is the diversity in generations. And you see traditionalists, the boomers, Gen X, millennials, and so if I'm trying to send a message for boomers, I'm not going to use the same methods, the same words, and the same tools that I will do for the millennials, because it may be that the boomers, baby boomers, prefer maybe TV and radio. And if I need to send something in writing with a very decent size of font so they can read, because baby boomers, we actually need our glasses to be able to read. So if you give us something in font 8, it's not going to happen. But for millennials, I'm not going to send something maybe in news radio because they don't listen to news in a radio. So I need to maybe go for social media, important issues in communication. Now, another area of diversity is the rural and urban populations. And what are we talking about that? We know that 88% of Virginia is rural, but only 26% of Virginians live in rural communities. Why is that important? Well, it is important because they may not have enough broadband in some areas, and you know about that. It may be that people in rural areas don't have the iPhone 15 to start with. They may not have access to tablets every day. And it's something that we need to take into consideration because if I need to talk about health, do you remember during COVID, everybody was doing the telehealth? We cannot do that very easily in some areas of Virginia. Then alerts, they may go in different hats to be able to get to everybody. And if we are looking at distance learning, that is not going to happen in some rural areas in Virginia that they don't have enough broadband communication. Again, same thing when we're talking about the diversity in sex, gender, sexual orientation, because we need to understand really the behavior and attitude to these different groups to create that messages that they are appealing to them so they can really follow us and understand what is happening if we have some advisories or if we are answering the phone with some particular instructions. In the culture of health, we need to talk about race and ethnicity. And when we talk about that, if you see over there in the past 10 years, we have had a change in population. Hispanic Latino population has grown a lot in the multiracial populations, and the white population has decreased. And I mentioned that because when we start with COVID, and I was part of the team working on that, communication was key, but we had so many other pressure elements. People was dying in the hospitals. We were looking for some alternative options. Everything was closed, so people was not able to work. They were depressed and with anxiety. So communication was kind of in a second layer. And what happened is that, let me tell you the story, in our official website in Spanish, we were telling the Hispanic community that they don't need COVID-19 vaccine. So the media pick up on that and everybody started talking about discrimination and you can figure it out. That was not the case because in the English version, the website was saying that the Hispanic community is not going to be forced to get vaccinated. If you just want to do the COVID test, feel free to come just for the COVID test. Communication. So that is when we start turning a little bit from translation, because that was about translation, to messaging transcreation. And we're going to talk about that at the end. Okay, let's go again for your understanding of different topics. And I don't want for you to go to your phones and start looking for definitions. Please, just tell me in few words, like, what is bias? And you can say, is something good? Is something bad? Is something I like? Is something I'm not familiar with? Just very plain and simple things in that way. What do you think is bias?
Slant, prejudice, lean towards one choice. Mm-hmm. My baggage, if you believe something we know nothing about. A prejudgment, mm-hmm. Preference for a particular way, a predetermined mindset or a preconceived notion, mm-hmm. Treating people differently, usually considered negative, believe something in one way, and a personal slant on one subject based on your past.
Okay, Kate, let's keep asking the other question and they can keep writing while I'm talking. The second question is, what's stigma?
A label, negative beliefs, mm-hmm. Labeling.
Okay.
another preconceived notion. Yep, negative judgment.
Okay, let's go for the third one. What is discrimination?
Different standards applied on race, being unfair or unjust, separating out, treating others differently, limited opportunity or freedom.
Good, good. Keep writing about that and tell me, what is equity?
Treating everyone the same, fairness, equal treatment, even playing field,
Okay.
Quality across the board.
All right. Let's go for the fifth one. What's racial disparity?
Treating races differently, differing access, differences due to race, one group is less treated, unequal access, imbalances.
Okay. And the last one, what's infodemic?
So I don't know. Don't know too much. Not sure.
Okay, let's keep moving and please keep writing because it's very important. We can read later whatever you're putting over there. Bias, you already told me that you know what is bias. So pretty much I don't need to start defining things because it's very well understood. But it's a natural human tendency, unfortunately. And the problem is what interferes with our decision-making process, because then it makes it really prejudicial and unfair. And the explicit bias is very easy to understand because it's very direct. People knows that they are biased about something or someone. And one example is when you put a sign that says whites only. No question about that, is explicit. Now, the implicit bias, that is sometimes tricky because it's expressed very indirectly. And some people is not even aware that they have this bias because it operates subconsciously. Like a property manager that is going to check criminal background in all African Americans and not in white people. So that is the difference. May not figure why is he doing that, but he's doing that. It's implicit. Now let's go for stigma. And again, I'm not very good with definitions, but there are very fantastic definitions over there for every term. And let me tell you that I'm a co-organizer of the Howard University Stigma Conference every year. Now is the year 14, unbelievable. And we define over there stigma as a social opportunistic disease that attaches to many illnesses and increases morbidity and mortality rates. And why do I have Lady D over there, right? Okay, this is the answer. Lady D came to visit us in the US many years ago, and in her visit, she was trying to visit with the children and the babies that they were abandoned at Howard University Hospital because they were born HIV positive. Chelsea is one of them. Actually, it's not her name because we cannot disclose the name of patients. But yes, Chelsea was one of them. Chelsea survived just because she was to survive. We didn't have medication at that time. And then as soon as they start with clinical trials for children, she was enrolled on that, and she was doing pretty good until she became 18 and decided to go to college. And she wanted to be a reporter, actually. Very good. She was going to college and coming every month for medication, and she knew that she needed to come for checkups and everything. Chelsea used to live with foster parents because she was abandoned at Howard. And then one month she didn't come, and then for the second month, so social services was going to visit Chelsea and see what was happening, and she was nowhere to be found. So nothing that we could do about it, but waiting until 1 year passed, and she appeared in the emergency room of Howard University Hospital, and she was really sick, very weak and very thin, and she was refusing medication. So she was hospitalized, and people talking to her about that we have very new medication, that they don't have side effects, that you can have a normal life, etc., etc. And she was refusing medication. And the reason she was refusing medication is because one of the classmates at college disclosed her HIV status on Facebook, and stigma started. And she was totally isolated. She says she was calling different names. They didn't know how she was infected. And this kind of life she didn't want it. So after another couple of months, Chelsea died. She didn't die of HIV/AIDS. We had the medication for that. All the medication was there. She died of stigma. So when you hear the term stigma, I don't want you to go to a dictionary to look for the definition. Stigma can kill. And that is very important when we communicate and we use stigmatizing words or we have stigmatizing behaviors, because it really kills people. Let's go for discrimination. And we know what it is, so I don't need to describe that per se, but we know that the direct is very direct. And it may be because of gender, language, disabilities, race, ethnicity, or any other reason. As you can see, the sign over there is so direct. Waiting room for colored only, and it's by the order of the police department. The tricky one again is the indirect, because people say that they are treating everybody the same. That is not enough. If we treat everybody the same, it has disadvantages for some particular population groups. Example, if we speak in English with people whose limited English proficiency, they cannot understand. Or the picture that you have there. If everybody the same, just put an escalator. Then the one who comes in a wheelchair, well, I don't care much about it. This is discrimination, and we know that there are laws against that and that protect people with different disabilities. So when we talk, when we speak, when we communicate, we need to start thinking about that everything we say is in the context that address the needs of different people. Same thing happens with equity and equality, because people confuse the terms. And equality goes again for everybody the same. The same opportunities are going to leave disabled people and aging populations, maybe without access. As you can see, the clinic is down there. What about if you jump into your wheelchair? Equality, they cannot do it. Equity actually gets everybody what they need. So yes, if we put a ramp, the person can get to the clinic. So that is the difference between equity and equality. Now, let's go very briefly with inequality. And inequity, we are looking at sometimes a question of how we distribute goods. And we make the difference because wherever people was born or the age of somebody. We know in the US there are lots of places that we call food deserts. And then we tell people, hey, you have diabetes, you need fresh veggies and fruits and whatever. They need to take a couple of buses or drive an hour and a half to get something fresh. So that is inequity. So we need to think about when we are talking to people and we give messages that inequity exists. If we're just going by the book and telling people you should eat this and this, and we didn't see the cultural piece that they live in a food desert area, people cannot do it. We are telling undoable things. The other example is with the vaccine. And we know that because COVID has been with us for now 4 years. Do you know that 83% of the vaccine was distributed in rich countries? Probably you figured that one out. But did you know that just 0.2% went to poor countries? And that is what prolonged the pandemic, because people in poor countries, they were getting infected and were going from A to B and C. So again, so you remember equity and equality. When we talk about issues of diverse race and ethnicity, well, remember that we start increasing our diversity when Europeans were coming to whatever is the US in the 15th century. And there are lots of benefits of this diversity because intergroup relationship, there are new ideas, and people is learning different approaches to having better life outcomes. The issue is that we need to understand the facts of racial ethnic diversity to be able really to develop this culturally tailored communication. So let's pay attention when we are talking to different racial and ethnic groups. I talk about disparities, and since I don't want to talk about definitions, it's just for you to see a couple of things. COPD is higher in rural America. And with CDC, we have the information. I was wondering how many people in rural America wake up and go to CDC, what do I need to do or not? Information and communication is bad. It's very poor in rural America. And it's where we should be emphasizing about COPD, but we're not. This is one of the worst disparities that I have seen really in rural areas. Do you know that in rural areas, for every 10,000 people, there are 13 physicians? 13, not mistaken. In primary care, just 5 for 10,000 people. But if you see on the other side of the spectrum how disparities play a role, only 6% of all the OBGYNs in the United States work in rural areas. What happened with women? There are women there that they need an OBGYN. There are pregnant moms that they need an OBGYN, only 6%. That is called disparities. We need to do something about that. Many rural communities have lost their hospitals. And we can see that in this period, 113 rural hospitals closed. And I'm talking 2010 to 2019. So nothing with the local government or the past government or whatever. It's 2010 to 2019 and hospitals closing in rural America. We're talking about infodemic. And that's another thing that make us diverse, because although everybody suffered infodemic during COVID, which is the overabundance of information, and the problem was that not everything was true, there were fake news, that infodemic is going to create anxiety. The problem is that when people has low health literacy is when it creates confusion and increased conspiracy theories. And we have heard so many conspiracy theories about COVID and other issues. It's people with low health literacy, the ones who suffer more from infodemic. So diversity is affected. I have mentioned several things over here that can influence whatever and how we communicate. In the chat room, can you tell me what other things can interfere or influence communication with diverse population? What are we doing, Kate? How many people is answering?
Language barriers, hearing.
Yeah, good. Anything else?
Fear.
Yep.
Language, social comfort. Pictures not match what I look like. Need glasses to read. Mental health blindness. Uncertainty about translator correctly sharing message. Digital access. These are good.
Okay. So thank you so much for sharing. Let's go to the learning objective 3. So we have time for some of questions and answers at the end. And pretty much the objective 3 is really about health literacy. Health literacy is key to communicate, and people sometimes doesn't understand that completely. But yes, it's a key for communication. And now what's health literacy? What do you think is so important? I'm going to let you right over there, even though I'm going to continue talking. In health literacy It's the cultural, cognitive, and social skills which determine the motivation and ability of individuals to gain access to, understand, and use health-related information. Do you remember I told you that I don't like definitions? I love that one. It's WHO. I love that definition because it makes us understand that it's not just cognitive. Cognitive is if I'm teaching you, this is diabetes, that's a hypertension, this is a cancer. It's not. Health literacy is cultural and it's social as well. It's a skill we can teach and skill we can learn. And we are not teaching just cognitive issues. We are teaching people to get motivated and use their own abilities to gather information. So if it's a person that is illiterate, is to let the person know, ask the doctor. So when the doctor at the end says, you have any questions for me, is to tell the doctor, I don't know, what are you talking about? Can you repeat everything? I don't know, what are you saying? I don't remember when you said that I'm taking my medication. That is it. Use their own ability. For other people that they are in the higher spectrum of health literacy, maybe could you recommend me some particular websites or books so where I can increase the knowledge about my illness or my health? So, and remember, October is Health Literacy Month. What's the difference? Because people confuse very easy health literacy and health education. Well, health education, we know, is a public health activity and people go there and learn about a particular topic. But health education is never going to pay attention of personal motivation, cultural background, social skills, the providers and the patients' biases, and there are so many at both ends of the spectrum, learning disabilities, stigma, or anything like that. So this is health education. And you can see very straightforward. And health literacy is really multidimensional concept. It's motivation, it's understanding, it's so many things. We have different sessions just for health literacy for the ones who are interested on that. The problem that we have is that in the US, we have a system that demands so many things from people. And when we increase a little bit their skills, the demands and expectations change. If you are in some European countries, you don't need to navigate the system like that. You make your appointment, it may take you a longer time, but you get there and you're concerned about your health or your illness and what to do, what's the medication. And I'm here, you need, before talking about going to the doctor, understand Medicaid, Medicare, Obamacare, Blue Cross Blue Shield, primary care, family practitioner, referrals, copays, out-of-pocket, enrollment periods. And when you're learning a little bit about that, next year, what happened? They changed the rules of the game. So that is our problem with health literacy. And health literacy embodies all these skills that we need to really develop and understand to maintain our health and improve it. And if we're missing one of them, it may not work in the way we expect to work. Why are we talking about health literacy? Because 9 out of 10 adults have difficulty using everyday health information. I'm talking Walmart health information. I'm talking CVS pharmacy health information. That is a huge problem. So every time we have a little bit of health information, just one person is going to understand. And just a second, there are not the new immigrants because people with limited English proficiency do not participate in these national surveys. They're not allowed to participate. And that is reported by the National Center for Education Statistics. We have a problem here. We have a huge problem with health literacy. And if we look at by race and ethnicity, we wish that everybody could be in the base, in the green part of the spectrum, proficient in health literacy, people who you can give instructions and tell them what to do and what not to do, and they will do it. And we say, oh, this patient is compliant. No, this patient is health literacy proficient. So they are doing exactly what we meant for them to do. 12% in the total population, 14% in the white population, 2% are proficient in the Black population, 4% in the Hispanic population. Of course, we don't ask to participate doctors, nurses, or social workers because that would be unfair. The problem is that if you see in the top, the below basic and the basic health literacy skills, they are going to confuse everything and not understanding instructions. So it's not something that we are looking to increase, it's something we have to change, because otherwise what happens is that people doesn't understand about preventive care, use of condoms, go for a vaccine, do your mammogram. Zero. It doesn't understand that. They visit the emergency room instead of the clinic because the emergency room is open 24/7 and the clinic closes at 5, and they have more hospitalizations. But one thing that we don't talk about frequently is the high healthcare cost. Billions every year. If we could use these billions to improve health literacy skills of the population, we will save lots of money. So we need to know the health literacy level of the target population to develop the communication that we need, to develop the proper message. If it's a person with below basic health literacy skills, probably infographics, or if you're volunteering in some place, it's not go to the second floor, make a right, and then make a left, and then after the bathroom. It's not going to happen. I'm going to tell you one thing at a time, or let me take you there, because don't everything is going to get confused and people will end up in places that they don't need to be and they don't complete whatever we ask them to do. And remember, patients with low health literacy, yes, emergency room, hospital stay more frequent. They say that they don't follow treatment plans. They don't understand the treatment plans. And of course, the mortality is going to be increased. So the factors that influence health literacy, we have gone through probably all of them, if not most of them. So just to remember, yes, it affects the social determinants, the language, the culture, equity, the stigma, bias, race, and ethnicity. And we have it listed here, but they are not just these factors. So let's go to analyze some of them. If you can come back from wherever your brain is right now and pay attention just to this slide, the social determinants of health and health literacy. Just think about one thing. Life is a combination of a genetic lottery and a geographic accident. So you didn't choose your genes, to be more clear. Nobody, I didn't choose my genes. It's a genetic lottery and a geographic accident. Nobody raised their hand to say, I want to be born in New York City or Paris, France, or South Sudan or Djibouti. It's a geographic accident. So we need to see everybody in the context that we need to identify what are your differences, what are the gaps, and how do I deal with this? Like I mentioned before, geographically speaking, in Virginia, there are some areas that they don't have enough broadband, and people may not have laptops or cell phones. So communication is there. I have been talking about equity before, so the only thing that I want for you to remember here is that every time we are trying to communicate or we think about communication, think about people with disabilities, sign language, braille, how to communicate with people that is aging, how to communicate with the youth. They have different perspectives in life. We need to have different messages for different groups. And as I mentioned before, culture is pretty challenging for health literacy because it may put patients and doctors in different spectrums about what is causing that disease. I hear people that says, I was sleeping bad and that is what I have, this problem with my back or my stomach or so. And having a regular diagnosis is maybe unacceptable for people. Hearing that maybe I need to do some testing because there could be a cancer. It's like, no, I just kind of, I was sleeping bad and something like that. It's a cultural issue. And you cannot dismiss the culture of a person. You need to know how to communicate with that person. Same thing, rights and protections are part of culture, and we should provide the advice or the treatment is part of a culture. But talking about culture, that is a very interesting thing. It's affecting really the perception of health and illness. And when we are thinking about cancer, COVID-19, people may say COVID-19 doesn't exist, or is the evil eye, or is voodoo. And that's it. It's a cultural issue. And we cannot communicate with people unless we understand their background. And we're not going to say to them, no, this is not voodoo. We need to look for the best way to penetrate in the communication scheme and learning how to communicate with people so they can understand a little bit better and improve their health. But the other thing is the type of treatment that patients prefer, really. When I came to the US a little bit more than 30 years ago, I was at the Howard University Hospital, and I started learning that if you have a headache, if you have stomach ache, if you have diarrhea, if you're feeling depressed, if you fought with your husband, etc., 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 chicken soup, pretty much. And that is the type of treatment that some people prefer. And when we were talking to people and communicating, is to say, what are you talking about, chicken soup? No, it's to say, how about if in addition to your chicken soup, you take this medication, communication. Now, during COVID, it has been a challenging time for superstitions, fake news, folk medicine, beliefs, myths. Faye, do you remember people saying that we have trackers? Well, I might have 5 trackers because I got vaccinated for COVID. Well, who knows? And that my DNA is going to be changed. Oh, I fear God and not COVID. We don't need to contradict people ideas or cultural beliefs. We need to learn how to communicate with people to help them to understand some things that can protect them and improve their lives. Again, I have been talking about these issues of the cultural competence continuum, and just for the purpose of emphasizing that is improving cross-cultural communication in situations. Again, folkloric medicine, and I hear many people, I'm not gonna say the volunteers, when somebody's, our coining first, or cupping, or acupuncture, or massages, or sweeping. So we need to respect folkloric medicine because chicken soup is another folkloric medicine we accept pretty good. When we communicate, it's not dismissing, it's understanding. This slide is completely old because it's 2022. In COVID age, it's like a century old. The bottom line is that we knew that there were more African American people dying with COVID-19 and more Hispanic Latinos really getting infected. And one of the issues was the lack of health literacy or poor health literacy. Of course, it's one of the aspects, because what happened is that many of our communities were in the front desks, were selling in Walmarts, and so were really exposed to the virus. And the other reason in the Hispanic Latino community that sometimes people, there were 2 or 3 families living in one department. But health literacy was playing an important role because the misunderstanding was improving the issue of the community don't believing in whatever they were being told. So it's maybe a conspiracy issue, and they were not following some of the paths they could follow. I'm not going to talk about bias, stigma, discrimination, but they are real barriers to health literacy. Let's go to the objective 4, because I think we still have a little bit of time to go through this, because it's so important. And it's increased the knowledge regarding the importance of messaging transcreation for effective communication with diverse population. And even though I don't have any slide, can you guys write for me what is messaging transcreation according to you? And Kate, could you read a little bit about to see how much we know about messaging transcreation?
Don't understand the term transcreation.
Okay, good. There you know. Anybody
Not
else?
sure. And, okay, somebody said involving the communities of culture in creating messages.
Okay.
New term, never heard the term, don't know.
All right. Okay, so let's start from the beginning, and thank you so much for letting me know about that. When we're talking about message and transcreation, is going to feel something that we are going to use with diverse populations. And mentioned before, we have an aging nation not ready to communicate with them, and we're going to talk about population segmentation very briefly, because messaging transcreation is kind of take several training sessions to master it. But messaging transcreation is going to require a little bit of additional skills. But if you know it, I think you can manage it. So when we are talking about messaging transcreation, we are talking about transferring ideas from one language or culture to another, not words. People used to translate, and that is use one word in one language to another language. Yes, see, transcreation is going to transfer the idea from one language or culture to the other. We use a lot transcreation for many years and more, and universities also because of research issues. The important piece of transcreation is that the whole process is going to adapt the initial message, is going to use the language and the culture of the other group, but it's going to maintain the tone, the intent, and the style. So whatever you try to say is going to be conveyed in another language or for another cultural group. That is transcreation. Translation, words from one language to another. Transcreation, ideas from one language or culture to another. So yes, we take into consideration the language, but we consider the audience. Who am I sending this message to? And the culture and the emotion that people has in front of the same words, so we can use the whole idea into the other group. And yes, we are using transcreation for many years when we're trying to communicate, let's say, with baby boomers. We try to design something that is appropriate for them. And if we put examples, we try to convey the music that they used to like or listen, because we are transcreating a message. And if we're doing it for this new generation, we're going to use their own words and music that is appealing to them. And we use it too for limited English proficient individuals. So translation is a very obsolete system. It takes too many misunderstandings because it's just replacing one word in one language with another word in another language that may not have the same meaning. When we transcreate, we need to segment our population. So who are the ones from different generations, different skills, different beliefs, and then we can create or develop a message that is appropriate for this particular group. It's not for everybody. It's not for everybody who speaks English. It's not for everybody who speaks French. It's for the ones who speak English or French, and they may be senior citizens, or they may be with some disabilities, and I need to transfer things in a different way. And that is what we use. We use the generation, we use the gender, the age, the ethnicity, the disability, sexual orientation, race, ethnicity, their faiths, and the limited English proficiency. And based on that, we select a particular group that we are trying to send the message, and is understood in the same way we intended initially. Since we're talking about limited English proficiency and communication, and you guys know, because I know that you call a translator or an interpreter if you need it, because being volunteers, we encounter different populations. So it's true, we need to call it. But sometimes people confuse the terms. The translator only works with written documents. So if you need to call a translator, it's because you want something in writing being passed from one language to the other. If you need a verbal, you need an interpreter, or sign language, it will be an interpreter. The problem is that sometimes we call an interpreter or a translator, and we are not sure if they were already trained in how to assess health literacy in English and Spanish and in other languages. And that is very important, because if the person tells you the level of health literacy that the person has, you start looking into how I'm going to communicate with this person, something that I communicate with the other that is a higher level of literacy or health literacy. And it was very simple to say, hey, just do that, and this is the pamphlet. We cannot do that probably with people with very low health literacy skills. And given a pamphlet, it's not going to work. So pay attention to when you call for an interpreter or translator that they know how to assess. We can assess health literacy in a minute and a half. And that's another training session that is not complicated. And of course, in medical settings, it can take us 2 hours, but we're talking in real life, a minute and a half take us there. So transcreation and population segmentations are key for us to deliver the message that is understood by the people we're trying to convey the message. And we divide these groups into smaller groups, or whatever we call segments, that they have similar needs, similar values, similar characteristics. So we use 4 main areas like demographic, psychographic, behavioral, and geographic. And then over there, we look for the health literacy skills. If the person is completely illiterate in any language, the cultural behavior and the proficiency they may have or not in English. As we know, and I just put it over there to clarify a little bit the ideas, demographics. We do it in every form that we have, the age, gender, marital status, and so forth. They are just attributes of a person. The behavioral is more the actions, and that is important to us because we want to know if this particular group likes to read, to create very nice material, the pamphlets also, or they are more listeners, or they like an online communication, or if they like some particular social media. Because in that way, we can communicate with people in the way that is going to work for them, because we know what is their behavioral understanding. And then we go for the psychographic or attitudinal, and that is a little bit tricky because it's how people perceive their interests, their mindsets. So many times they don't tell you up front, but we learn while we're talking to people because it's whatever they like or dislike. You like a brand or you dislike a brand because you like or dislike. I think I'm not going to make you change your attitude unless something is contaminated or something like that. Just you like that. It's the kind of lifestyle choices or values. And do you remember there were people that like to go vaccinated for COVID and they were in long lines in cars. And there were people that perhaps they didn't have doubts about vaccination. Same thing with the use of masks. And the geographic is really what we have been talking about. If people is rural, is urban, the zip code, so we know what's going to work for a particular group. And that is just to put it in a different context, but what I was talking about. What I was trying to mention here is that for very low literate or low health literate individuals, we need to use infographics, minimal text, maybe almost nothing but a telephone number. And remember, that is something that I put there as an infographic and remind us that 1 in 5 adults in the US lack basic literacy skills. Literacy. They may be able to read, but they are not able to understand whatever they are reading. I'm not talking about health literacy. That is a total different step in people's life. And again, limited English proficient individuals, people who is the new immigrant, they don't participate in these surveys. So it's just our population, typical population here, and 1 in 5 have problems with literacy. And what are they going to tell us? Oh, I didn't got my glasses with me, and whatever, but in reality, they have problems with literacy. So minimal text will solve the problem. On the other hand, as I'm talking about literacy, for health literacy, remember that only 10% of adults have the skills to use health information. And we give tons of pamphlets and information. What about the other 90% of us? Have we thought about that? And when we think about these issues, infographics is going to help us a lot to improve communication. I have another things here for you. If you see that more than 4 in 10 adults with an income below 30,000, they do not have broadband services or traditional computers. Probably you didn't know that. Is the internet communication a good option for people that earn 30,000 or less? And sometimes the advisories are for these particular populations because we might need them to evacuate to another place. So digital communication may not work as we plan. And if we see in the other end of this picture, it's like what over 98% of Americans have access to the internet. 1 in 4 doesn't have it at home. They don't have it at home. They go to the store, they go to the libraries, or at work, they try to check everything that is coming via internet. So digital alerts for this 1 in 4 American that they don't have the broadband at home. It will be something we want to do. And think about it because these are pieces of communication. The barriers of communication, we have gone through everything, and again, I'm calling to your attention that we have an aging nation, and we need to start thinking about how are we going to improve communication with our aging nation. This is almost the end of the presentation, so I was trying to bring you some examples because all the volunteers probably are in different scenarios like that. And there's one thing that we notice, and there are researchers that they are working at George Mason University with communication issues. I'm helping the health risk communication group. So there are adjectives that probably we don't need to use, like vulnerable, minorities, high risk, if we can use other phrases like groups that have been marginalized or under-resourced communities. That works a little bit better. We can use phone numbers in very large size and very large font if we want a message to be passed to aging populations. Another thing we notice is that we need to be very specific when we are referring to a group and avoid these issues to mention like ethnic minorities, the disabled groups or the religious sects, and go more for what is the community you're trying to refer to. And we need to start avoiding violent connotations, like tackle this and combat that if you're talking with the community groups. Another thing that we notice is that sometimes we're blaming a group for a behavior. Like when we say people who refuse vaccination, whatever, and that can be a little bit negative. Perhaps we can say people who have not yet been vaccinated. That kind of sounds a little better if we're communicating with a group. And so, assess diversity, assess health literacy, look for the values of the traditional medicine. Remember, your chicken soup and every other traditional medicine have the same value. And every communication needs to be developed for your target population. We need to segment the population because we cannot have one message for everybody, and test the message with the target population. And as we say at the beginning, we're going back to the beginning. One size does not fit all in communication. So it's very summary: health literacy, culture, messaging transcreation, which you didn't know about. There are trainings about that. And please, please, please don't use translation. Not only obsolete, but it creates lots of confusions. In many versions, as many versions that you can have of something, and if you cannot, infographic gets to everybody. That's what we're talking about. The culture of diversity. Diversity in communication takes health literacy, culture, and transcreation, pretty much as a summary and a little bit of references. And I don't know if you have any questions for me.